Hello to everybody. It's a pleasure and honor to chair today this Theramex-sponsored satellite symposium at EMAS, and we will discuss for 1 hour how we can overcome challenges with new opportunities, HRT for menopausal women. I'm Professor Rossella Nappi, Chief of the Research Center for Reproductive Medicine and Director of the Gynecological Endocrinology and Menopause Unit at the San Matteo Hospital Foundation at the University of Pavia, Italy. And I have the pleasure today to have 3 colleagues and friends. They are amazing speakers. The first one is Professor Tim Hillard. Professor Hillard is a consultant gynecologist at University Hospital Dorset, Poole, UK. The most relevant information on his CV are that he is the past president of the British Menopause Society and is currently a board member of the International Menopause Society. And he will be the vice chair of the next World Congress of EMAS in Lisbon, October 2022. Professor Hillard will give us a talk, Prescribing HRT, Practical Recommendation. Then we have the pleasure to have Professor Petra Stutte. She will give a talk on the advantages of the hormone progesterone, impact on health and well-being. Petra Stutte is Deputy Director of the Section of Gynecological Endocrinology and Reproductive Medicine at the Women's Hospital at the University Clinic in Bern, Switzerland. Petra is a board member in several scientific societies such as the German Menopause Society, Swiss Menopause Society, and Swiss Society Against Osteoporosis. And she's also the editor of the bi-monthly First to Know newsletter of the German Menopause Society. And last but not least, Professor Santiago Palacios. He will give a talk presenting the study REPLENISH, Efficacy and Safety Data. Santiago Palacios is the director of the Santiago Palacios Institute of Health and Women's Medicine in Madrid, Spain. He has been very active in the field of menopause, past president and honorary member of the Spanish Menopause Society, and at present, together with Tim Hillard and myself, is serving on the board of the International Menopause Society. Here my disclosure of interest. And I just would like to say some few words of introduction. Why we need this discussion? We need this discussion because HRT decision-making is complex. We know very well in our everyday practice that menopause is considered a natural event on one hand. On the other hand, we have a multitude of phenotypes, different phenotypes of women out there. So we really need to develop very good communication skills to counsel our patient, especially on the risk-benefit balance of treatment. And this is essential, dear friend, for a real individualized management. And this is the reason why now we start listening to the first speaker, Professor Tim Hillard. Please, the floor is yours.
Thank you, Rosella, and thank you very much, Theramex, for inviting me to give this presentation at this symposium at EMAS. This afternoon, I'm going to speak to you about prescribing HRT, some practical recommendations. These are my disclosures. Of note, I'm a board member at the International Menopause Society, an associate editor of Climacteric, and a board member of the British Menopause Society. What I'm going to cover in this presentation are, first of all, some initial guidelines and recommendations, and then focus on the practical aspects of prescribing HRT and choosing the right one. The key considerations, such as whether it's to be cyclical or continuous, selecting the right estrogen, selecting the right progestogen, troubleshooting when things don't go quite according to plan, and then finally a treatment review schedule. So I don't think this audience needs much reminding about the place of hormone replacement therapy in the management of the menopause, but just to emphasize that these international recommendations are out there. These are the latest ones that are available, which all essentially say more or less the same thing, that for the vast majority of early postmenopausal women, and by that we mean women under 60, HRT is a safe and effective option for the relief of menopausal symptoms and the prevention of osteoporosis. So I'm not going to dwell on that anymore. I think the case for HRT is very clear. And what I want to focus on now is the practical aspects of how to prescribe HRT and which one to use. So the first thing we need to discuss when we're choosing the right HRT is whether or not the woman is hysterectomized. This may seem a very basic question to an audience such as this, but it is surprising how many healthcare professionals seem to struggle with this simple concept. If the woman has an intact uterus, she needs progestogen, and the options are as listed on the bottom left. You can either use oral estrogen with an oral progestogen or the levonorgestrel IUS. You can have transdermal estrogens in the form of patch, gels or sprays, and that can be combined with oral progestogen, transdermal progesterone or levonorgestrel IUS. The additional option of tibolone. In some countries, we have available the estrogen plus the SERM combination, beta-doxyphene, and in some other countries we have estrogen implants available, but they have to be used with oral progesterone or the levonorgestrel IUS. For those women who've been hysterectomized, there's no need for progestogen, and therefore the choice is simpler. It is simply oral estrogen, transdermal estrogen, or possibly tibolone, or an estradiol implant if that's available. But as far as initial management is concerned, the first question is, do they need progestogen or not? So the most difficult choice really is for the perimenopausal woman, the woman who is clearly not yet completely postmenopausal. And we have 4 options to consider. The first and the most popular one really is the continuous estrogen with sequential progestogen. This is the best option for women who are still cycling, and the idea is that sequential progesterone should coincide with their natural cycle so they have a regular monthly bleed. It's easiest if you start the 28-day pack at the day 1 of the natural cycle, hopefully trying to coincide things. The downside of this option is that it doesn't really control premenstrual symptoms because they still have the sequential progestogen during the second half of the cycle. This option does allow us to use transdermal therapy as well, and some options are available. The second option to consider is that of combined contraception, and this could be a good option for some of the younger women, but there are other factors to consider. First of all, that the combined contraceptive pill is relatively contraindicated in women over 45, and certainly if there are other medical conditions, this may not be an option. However, it does have the advantage that it can be used to several cycles in a row, and that helps to control premenstrual symptoms, and it often gives very good cycle control. There are low dose and 17-beta estradiol options available as well, which can make it more attractive for the 45 to 50-year-old age group. So another option to consider. The third option, which is also extremely popular, is using continuous estrogen and the levonorgestrel intrauterine system. This has the attraction of providing no bleeding. It doesn't control premenstrual symptoms, but it does provide ongoing contraception. So for the perimenopausal woman, it has 3 potential advantages of contraception, controlling bleeding, and providing progestogen addition to the estrogen. And again, transdermal estrogen options are available with this combination. The fourth option is perhaps the most contentious, and that is continuous estrogen and continuous progestogen. Many women, after having problems with their bleeding, often would choose to have a no-bleed option and ask for this. However, for this group of women in the perimenopause, this may not be the best option. The amount of progesterone and estrogen in the products is not really enough to override their natural cycle, so they may well get irregular bleeding, and this may put them off taking hormone replacement therapy for later. They can still get PMS with this type of product, but it may be suitable for some women, but on the whole, this type of combination is more suitable for women who are clearly postmenopausal. So when we're choosing the right HRT, we need to look at the different preparations. A lot of the preparations come in predetermined doses and combinations, and we have to look at those to decide which is the most appropriate. It's really important to look at the components. And again, one of the problems we see in clinical practice is that in primary care, a lot of these people have started on one type of product without really considering what the different components are. So look at the different individual components of these predetermined doses, and then choose carefully as to which one you think is going to be most suitable for the patient. However, oral therapy is popular. It's very easy to use. You don't really need to explain to a patient how to use a tablet, and it's convenient. So many women do like to have the oral combination as a starting point. Transdermal estradiol does have advantages as it avoids the first pass effects, and thus can be preferred for those who have increased risk for VTE, for instance, such as those with a high BMI or past history. But for the average woman who has got no individual risks, it's not necessarily a huge advantage. The downside of the transdermal therapy is that the estrogen and progesterone combined patch is only available in one strength, and therefore, although you can use it cyclically, which you can use cyclically or continuously, but although you can use it, that gives you little room for flexibility if things aren't going quite according to plan. So I just want to focus for a minute on the thrombotic risk, because this is often the discussion about whether to use oral or transdermal has often centered around this. And I think it's important just to take stock of what we're talking about. First of all, the background thrombotic risk for most women is extremely low. And therefore, any increase in risk, although it may be a slight increase, it is on the background of a very low risk. And this, we know with the comparisons with oral and transdermal estrogen that there is a slight increase in risk with oral estrogen compared to transdermal estrogen. But for the vast majority of women, this probably isn't going to be of clinically relevant magnitude. However, for those women who have additional risk factors for thrombosis, such as those with obesity or known to have factor V Leiden abnormalities or other past histories of thrombotic disease, then this can be an additional increase in risk with oral estrogens. And in those groups, transdermal estrogens would be more appropriate. It's also important to be aware that the progesterone addition can have an impact on thrombotic risks. There's several studies that have highlighted that micronized progesterone doesn't increase risk of thrombosis, whereas norethistérone and MPA products do increase the risk slightly. So overall, the key points of this are that for most women, the marginal differences in clinical risk really are not that relevant. And for most women, it's important to get compliance with the therapy over and above anything else. However, for those who have individual risk factors for thrombosis, then transdermal therapy would be preferable. And if you are using either oral or transdermal estrogen, then micronized progesterone seems to have the lowest thrombotic risk, so is best used in that group with that increased risk. So the second point is that for choosing the right HRT, the fixed oral combinations are often a very good starting point for most women. Again, choose carefully, but start off with a simple oral combined treatment and then review, and we'll discuss that more in a minute. However, if there are problems getting symptom control or the patient experiences side effects, then it can be helpful to break the HRT down into its constituent parts. You select the estrogen you want to use by type, route and dose, and you select the progesterone you want to use by type and dose. So first of all, let's focus on the estrogen. We look at estrogen dosing and route. The different types of estrogen are listed down on the left. The most popular ones now that are used really are the 17-beta estradiol oral preparations and the transdermal estradiol patches or gels. There are low dose preparations, which often is a good starting point, moderate dose preparations and high dose preparations. And you'll note that the high dose preparations are actually doses that we are very familiar with and often for many years have been using as a sort of standard dose. But with lower dose options now available, we have got the flexibility to start low and increase to higher doses. A few important points to make is that it's usually a good plan to start with a lower dose and increase as the symptoms dictate. So if you haven't got symptom control, then you can increase to a moderate or higher dose. But if you have with a low dose, then you may not need to increase further. Younger women often require higher doses, and you may need to even go above the dose listed in the higher dose bracket on the right. And it's possible that, particularly with the lower dose preparations, you may not get complete relief of vulvovaginal atrophy symptoms. So in those situations, you might need to use additional vaginal estrogen preparations to control genitourinary symptoms. With the adding in a sequential progesterone, we really have 4 options between dydrogesterone, medroxyprogesterone acetate, norethisterone acetate, and micronized progesterone. Remember, the sequential progesterones are given cyclically and in combination with the continuous estrogen. All of them, apart from norethisterone acetate, are only available orally, but with norethisterone acetate only as part of the combined patch, you can give it transdermally. Again, you've got lower dose combinations and higher dose combinations. In general terms, we use the cyclical options require slightly higher doses than the continuous options, but it does vary depending on the product. It's important with progesterones to recognize that these are often the group of the preparation that causes the most side effects, and be aware that different progesterones can have different side effects in different individuals. So if you start with a micronized progesterone combination and the patient experiences some side effects, then try to look at perhaps a norethisterone as an alternative option, and vice versa. So don't just switch products to one which has got the same progesterone in it. Most of the commercially available preparations at the moment have MPA or norethisterone in them, but micronized progesterone and dydrogesterone are very good alternative options to consider. If you're really struggling with the progesterone control, the side effects, then you can look at reducing the amount of time you give it from 14 days to 10 days a month, but you need to be aware that this may cause increasing problems with bleeding, so it has to be balanced together. And of the difference between micronized progesterone and the other progesterones is it is a bioidentical, considered to be a bioidentical preparation, but we must be very aware that there are a lot of non-regulated products out there which call themselves bioidentical, which have not been fully tested and assessed. So it's important that when talking about bioidentical, one focuses on the ones that are regulated, such as micronized progesterone. With continuous progesterone, again, you've got the same options, but there's a number of other options one can consider. Some products have drospirenone in it as well, and of course you've got the levonorgestrel intrauterine system, which provides continuous progesterone, which is another option to consider and can be very effective in this group. We would recommend continuous progesterone for all women over the age of 54 because of the slightly increased risk of endometrial problems in women with sequential progesterone long term. The use of the continuous progesterone does allow a lower dosage, which can reduce cyclical side effects. And it's important to recognize that although all the products listed here are available in some countries, they're not all available in all countries. So additional tips that one might want to consider when thinking about hormone replacement prescribing. First of all, transdermal gel has a flexible dosing options itself, but has to be used in conjunction with oral or intrauterine progesterone. So there's no combination with the gel and transdermal progesterone. Dydrogesterone or micronized progesterone can be associated with less progesterogenic side effects, seems to have less adverse effects on the breast and thrombotic risk, and therefore is a very good option to consider when looking at either oral or transdermal preparations. Transdermal or oral estradiol plus the levonorgestrel intrauterine system is a very convenient no-bleed option, and it's associated with less breast density than oral norethisterone, so can be another option to consider, which may have advantages. Tibolone is an alternative option for some women, as is basidoxifene, which is available in some countries, although it's unfortunately fairly limited at the present time. So what about treatment review? Well, the general way in which we recommend this is done is that after having had the initial consultation and starting the patient either on something non-hormonal or HRT or vaginal therapy or combination of those, you review the situation around 6 to 8 weeks to see if there's been any effect on the symptom relief and whether or not they've had any side effects. If the option you've chosen is working well, then I would suggest review 6 months later. If it's not working well or the patient's developed side effects, then you need to look at the different therapies that you're on, break it down into the individual estrogen and progesterone components and make some appropriate changes. Then review again. If everything seems to be going well at 6 months, then review the situation again in a similar type of scenario. But be quite prepared to change the preparations if the patient is not responding in the way you'd expect. However, if they are responding well, we would recommend a 6 to 12 monthly review to look at efficacy and side effects, and also on a regular basis to review the individual risks, because as the patient gets older, various other comorbidities may develop, new research may become available, and the risk benefit profile may change, so that different treatments may need to be used. Finally, just where you can get some very useful further information available for those who would like to look more into this. All the major international societies have done a huge amount of work in trying to provide educational material, not just for their members, but for the wider medical professional and indeed the public. So just flag up the International Menopause Society. The recommendations on midlife and menopause therapy were published in 2016. They also have the IMPART series, International Menopause Society Professional Activity for Refresher Training, which is freely available, and it comes at 2 levels. Level 1 is already out and freely available, and level 2 is currently in the final stages of development, and this is freely available on the IMS website. The European Menopause and Andropause Society have done a fantastic amount of work on various aspects of the menopause and have recently published guidelines on genital urinary syndrome in the menopause and also on workplace in the menopause. And the British Menopause Society have produced some very useful tools for clinicians, which include a practical guide on HRT and also useful guides on testosterone prescribing. And finally, the NICE guidance, which was published in 2015, is an excellent overview of evidence-based menopause management and is currently up for review in the next 12 months. Thank you.
Thank you to Professor Illard for the very informative talk, and it's now my pleasure to give the floor to Professor Petra Stute. Please, Petra.
Welcome from Switzerland. It's a pleasure for me to give this presentation on the advantages of the hormone progesterone and its impact on health and well-being. So let's imagine this is your next patient. So this is a postmenopausal, healthy 52-year-old woman presenting with hot flushes, insomnia, and body weight increase. She's desperate and feels stressed out because of this seemingly uncontrollable situation. Her further personal history is okay, so she's a little bit overweight, but that's all. And she has a positive family history of breast cancer. So now I'm offering you several reaction types. So this is your first option. You tell her that obviously she's not able to control herself and that she should make a bigger effort. Your second option, you are also frustrated as you also put on weight and tell her, well, that's aging. Or you prescribe an antidepressant to reduce hot flushes and to improve mood and sleep. As body weight may further increase with the antidepressant, she should intensify her workout and improve her diet. Or you prescribe HRT as it stabilizes body weight and will also reduce menopausal symptoms. Or finally, you say, no, you strongly advise against HRT as it increases breast cancer risk and will increase her body weight even more. So now you can think about your answer. And while you are thinking, I'm giving this presentation and I'm going to answer the following questions. What does the term body identical hormone mean? What is so special about body identical progesterone? And what's the impact of HRT containing body identical micronized progesterone on breast cancer risk, cardiovascular risk, and endometrial safety? Well, let's start with the first question. The definition of body identical hormone is that these are compounds having the same chemical and molecular structure as hormones produced in the human body. So this definition implies that mode of application is not a criterion and source is not a criterion, as most exogenously applied sex hormones are made of yams and soy. Second question. What is so special about body identical micronized progesterone? Well, as you know, progesterone is metabolized to allopregnanolone or allo. Allo binds to your GABA-A receptors in the brain. And what is so special about GABA? Well, GABA is the most important and prevalent inhibitory neurotransmitter in our brains. So oral micronized progesterone supports sleep via GABA-A receptor modulation, and it also increases the anxiolytic effect of GABA by 160%. In addition, progesterone has anti-inflammatory and stress-regulating effects in the nervous system. So let's have a closer look at the impact of micronized progesterone on sleep. So progesterone levels significantly positively correlate with the duration of non-REM stage 3 and 4. That's our deep sleep, and that's what we would like to have every night. So in one study, which was a randomized crossover study in a few postmenopausal women without menopausal symptoms, it was shown that 300 milligrams of oral micronized progesterone was able to compensate for environmental disturbances during the night. In a second study, that was also a randomized placebo-controlled trial in women without sleep disturbances that also received oral micronized progesterone at 300 milligrams per day. In this study, it was shown that micronized progesterone significantly increased total sleep time and decreased sleep onset latency and awakenings. So let's look at stress, because our patient was very stressed out because of her symptoms. And the physiological stress reaction, as you might remember, is regulated by the hypothalamus pituitary adrenal axis, HPAA, and also by the autonomous nervous system, ANS. And allo was shown to strengthen the parasympathetic nervous system, so that calms us a little bit down. And there's one study showing that combined HRT containing oral micronized progesterone at 100 milligrams per day was able to reduce the HPAA activity by significantly decreasing basal serum cortisol levels. And finally, allo also supports the inhibitory hippocampal neurons, which in turn reduce the HPAA activity. So let's look at body weight, because most women are so afraid that they put on weight with HRT. But to be honest, there's no reason to be concerned, because already in 2000, a meta-analysis published in the Cochrane database systematic reviews showed that HRT does not have an impact on body weight and BMI. And the same was found by one of my students who did a systematic literature review on HRT containing micronized progesterone. And she was able to show that HRT containing micronized progesterone did not have an impact on body weight or even reduce body weight in normal weight postmenopausal women. And if we look at BMI, again, HRT containing micronized progesterone did not have an impact on BMI in normal and overweight postmenopausal women. So these are also good news. So now your patient is already very positive towards HRT containing micronized progesterone. However, she's a little bit concerned because she wonders, how is my cardiovascular risk? How is my breast cancer risk? And how is my endometrial cancer risk? So let's have a look at those parameters. So I would like to start with the impact of estrogens combined with micronized progesterone on VTE risk. And we have 4 studies investigating this effect. So first we have the 2 American RCTs, KEEPS and ELITE. And in those 2 studies, venous thromboembolism was assessed as serious adverse events. So in the KEEPS study, women were either treated with estrogens or sequentially combined with oral micronized progesterone at 200 milligrams per day or placebo. In the RCT ELITE, women were either treated with estradiol combined with vaginally applied micronized progesterone in a sequential manner compared to placebo. And in both studies, there were no significant intergroup differences after 4 or 5 years for VTE serious adverse events. Now we go to France. Here we have the ESTER study and the E3N study. The ESTER study is a case control study, and the E3N study is a prospective cohort study. In both studies, various estrogen-progesterone combinations were included. And the most important result is that estrogens combined with micronized progesterone does not increase the risk for having VTEs. Now we have a look at arterial thromboembolism events. Again, we have a look at the RCT KEEPS and ELITE, and again, arterial thromboembolism like heart attack, stroke, or angina pectoris were assessed as serious adverse events. And again, no intergroup differences for those events after 4 and 5 years. Now we go again to France. Here we have the French National Health Insurance System study, which is a nested case control study, including various estrogen-progesterone treatment combinations. And as was already shown for the VTE events, also for the ATE events, this study was able to show that the risk of having a second stroke was not increased if estrogens transdermally applied were combined with oral micronized progesterone. Now we have a look at breast cancer risk. And a couple of years ago, we performed a systematic literature research on this topic. We identified one meta-analysis showing that HRT containing micronized progesterone does not increase breast cancer risk. However, in this meta-analysis, treatment duration was not considered. And so we have to look at other studies. Again, we have the 2 American RCTs, KEEPS and ELITE. In those studies, breast cancer was assessed as a serious adverse event. And after 4 and 5 years, there were no significant intergroup differences between the treatment arms and the placebo arms. We go again to France. Here we have the case control study CECIL showing no increased breast cancer risk after more than 4 years of HRT containing micronized progesterone. So until now, everything looks very nice. However, we have the E3N study, as you already know, the prospective cohort study. And this study showed an increased breast cancer risk after more than 6 years of HRT containing micronized progesterone or dydrogesterone. Because this is such an important result, it's worth to have a closer look at the E3N study. So it's a prospective cohort study. Women are asked to answer a questionnaire every 2 to 3 years. And in this questionnaire, information is assessed on HRT, like product name, treatment start, treatment duration. However, the questionnaire does not assess dosing of progesterone and also not the number of treatment days per cycle. And we know that this is an important factor. So in the study, more than 80,000 women are included. 70% are HRT users, and mean duration of HRT is about 7 years. Follow-up is 8 years, and for the publication in the year 2014, more than 2,000 breast cancer cases were included. And this is the most important result from the most recent E3N publication from 2014 on the topic breast cancer. So on the left side, you can see that the combination of estrogen and progesterone or estrogen and dydrogesterone for up to 5 years is safe for the breast. However, on the right side of the table, you can see that if you increase the duration of treatment, that then breast cancer risk also increases. So for a mean duration of 8.7 years, a relative risk was calculated of 1.31, which means that the breast cancer risk increased by 30% if treatment of this combined HRT did last for more than 8 years. Now we come to the topic estrogen plus progesterone in endometrial cancer. Again, we performed a systematic literature search to get to know more about the impact of oral progesterone, vaginally applied progesterone, and transdermally applied progesterone in combination with estrogens. And you can see that the RCTs using either oral progesterone or vaginal progesterone showed a sufficient endometrial protection, and the scientific evidence was best for oral application of micronized progesterone, and the prospective cohort study E3N was the only study showing that after 5 years treatment with combined HRT containing micronized progesterone, that then the risk of endometrial cancer might increase. However, you may remember that I told you that the dosage of progesterone was not assessed in the E3N study, and neither was the number of days per cycle that progesterone was applied. Transdermal progesterone is not sufficient for endometrial protection. So we come back now to our patient, and you remember you had a few options how you could react, and I hope that HRT stabilizing body weight and reducing menopausal symptoms would also be your favorite treatment recommendation. So in conclusion, the authorities like FDA, EMA, and Swissmedic, they all have approved micronized progesterone on the market, which is a bioidentical or body-identical hormone. So it's not necessary to go to a compounding pharmacy. Progesterone has a neutral effect on metabolic parameters, and if given orally, it also improves sleep and anxiety. It's not associated with VTE and other cardiovascular risks. It's more breast-friendly compared to synthetic progestogens, and it provides adequate endometrial protection in studies up to 5 years. And I would like to thank you very much for your attention.
Thank you, Professor Stutte, for this beautiful presentation on the role of progesterone for women's health. And it's now my pleasure to introduce the last speaker of our symposium, Professor Santiago Palacios. Please, Santiago.
Thank you, Dr. Napi. Thank you, Rosella, for this introduction. For me, it's a pleasure to be here and to try to explain the REPLENISH study, but this is a phase 3 double-blind placebo-controlled study, 12 months. It's a multi-center trial evaluating the safety and efficacy of 70 beta-estradiol plus micronized progesterone oral capsules in postmenopausal women. Of course, perhaps this is the most important slide for me, because as the first time we have the combination of 70 beta-estradiol, 1 milligram, plus 100 milligrams of micronized progesterone. As you know, we were waiting during several years this combination because it was not easy to try to put together in relation with the differences in the structure and solubility. But finally, we have here, and this combination we have in one single capsule. This is something very important and exciting, and this is exactly the REPLENISH study with this beautiful combination. Let me to explain that this study was done in women between 40 to 70 years old, very young, with a normal endometrial biopsy and with a body mass of equal or less than 34 kilograms per meter square. Other important point, of course, were that the women, they needed to have 7 or more moderate to severe hot flashes per day, or if you prefer, equal or more than 50 hot flushes per week. The exclusion criteria were exactly the same criteria in all of the hormone replacement therapy trials. Contraindication, allergies, the history of breast cancer, or uterine and ovarian cancer, hormonal cancers, or history of thrombosis or coronary artery disease, and of course, severe chronic liver or kidney disease. Well, they are very similar. But let me to present here, this is exactly in the light brown square that we have in the slide, that the primary endpoints were, in terms of safety data, to analyze the endometrial hyperplasia incidence after 12 months of this combination. And the efficacy primary endpoints were the frequency and severity in moderate to severe vasomotor symptoms at week 4, that means after 1 month, and at week 12. These were one sub-analysis study. Well, you can see in this slide clearly the efficacy in terms of frequency and severe of the vasomotor symptoms. There are clear statistical significance after 3 weeks in both in frequency and severity. After 3 weeks, and of course, this decrease up to 12 weeks. That means that you maintain and you increase the efficacy. No doubt in terms of the efficacy in relation with vasomotor symptoms. In this other slide, we analyze the clinical global impression of the women. You can see in the right side that this is a score on a 7 points Likert scale from 1 very much improved to 7 very much worse. But again, you can see clear the huge differences between the group with hormone replacement therapy with estradiol mass micronized progesterone versus the placebo that is right in this slide. There are important statistical differences, and clearly the proportion of women who rated their condition of very much or much improved was important. 82% of women in the week 12, they consider that the treatment, they produce a clear improvement or a clear or much improved in relation with the symptoms. In this other slide, we analyze the menopause specific quality of life questionnaires versus placebo. We consider that a clinically important difference was defined as a change of -1. While in the hormonal group, in the red color, we decrease -3.8, and in placebo group, they decreased 2, but -2.2. The differences was statistical, clearly with clear statistical differences with more than -1.7. Again, we can confirm the beautiful result in terms of quality of life. Well, this slide is a beautiful slide because it's, for me, my understanding, it's the first time that before launch one product, we analyze in detail the sleep disorders problem. As you know, we consider the sleep disorder one of the most important ones in terms of quality of life in menopausal women with vasomotor symptoms. But we can say with this beautiful questionnaire that they have, in this questionnaire there are 6 domains over the past 4 weeks. We analyze the over past 4 weeks. And we can confirm that after 3 months, there are statistical differences in relation with the placebo, and this not change after the time, that means you maintain the efficacy in relation with the placebo in both, in the total score, and when you analyze the sleeping disturbances too. That means that this is an important treatment in terms of sleeping disorders, that this is so beautiful. Well, as you know, one of the most important principal objective were to analyze the safety data in terms of the endometrium. We consider that less than 1% of hyperplasia, endometrial hyperplasia, means that this treatment is safe. This is the FDA considered this, and the European Medical Agency too. Well, we had only one case of endometrial hyperplasia without atypia and no cases of endometrial carcinoma. In conclusion, only 0.36%, less than 1%. In other words, we consider that this treatment they have a protection in relation with the endometrium, no doubt in this case. And this was one of the principal objectives, very important for us. What's happened in relation with the side effects? Well, with more than 3%, we have the typical side effect, typical of the hormone replacement therapy in perimenopausal women: breast tenderness in comparison with placebo, headache, vaginal hemorrhage, pelvic pain, nausea. All of these points were higher in the treatment group versus placebo, but no the severe side effects. As you can see in the last line, you can see exactly 0.7 in the treatment group versus 0.7 in the placebo group. No more severe side effects, and the side effects in general were the typical side effect with hormone replacement therapy. Well, move on to one of the most important points in relation with the hormone replacement therapy treatments. Always we like to analyze what's happened in terms of bleeding or spotting. We can say that in the beginning there are more bleeding and spotting in the treatment group, but this disappear over the months. That means that we can say that after 1 year there is 97.8%, 98% of women in amenorrhea, exactly the same proportion that in the placebo group. That we can say, well, there is a little more, or there are a little more bleeding or spotting in the beginning, but then after some months, this disappear, and the amenorrhea is exactly the same than in the placebo group. When we analyze the consecutive cycles of no bleeding, we can say exactly the same. In the beginning, there are small differences, but then after 1 year, disappear these bleeding problems, and they have amenorrhea the same proportion than placebo group, no differences after 1 year. This is a nice result in terms of bleeding problems. What about breast cancer? Of course, we did in this study, in the REPLENISH study, we did mammography in the beginning and the end, and they have exactly more or less the same incidence as the screening mammograms in the women. And in terms of breast cancer, in the 1 milligram of estradiol plus 100 milligrams of micronized progesterone, only we had one breast cancer of 0.36%. It's also similar to the normal population at this age. That means that in terms of breast cancer saved after 1 year, we can confirm the same result that in the normal population. Move on to some important parameters as the coagulation parameters are. You can see here in the slide that all of the coagulation parameters, prothrombin time, antithrombin activity, protein C, protein S, all of them did not change by 12 months. They are exactly the same in the baseline than after 1 year. But this is important to say this. And this is exactly the same in the placebo versus in the treatment group. No differences at all. That means that we are sure in terms of coagulation factors. What about the lipid parameters or glucose? Exactly the same. We can say that cholesterol, LDL cholesterol, HDL cholesterol, glucose, and triglycerides did not change by 12 months after 1 year. Exactly the same proportion, exactly the same than placebo, no differences. And we can say exactly the same when we analyze the body weight, the systolic blood pressure, and the diastolic blood pressure. No differences between placebo and treatment group, and no differences in the baseline versus 1 year later. No differences, no change. Well, let me to summarize the REPLENISH study. We can say that this is the first time that we have a new combination, estradiol plus progesterone micronized, stable estradiol serum levels with taking one capsule of 1 milligram of estradiol. They provide significant vasomotor symptom reduction, this is clear. And the progesterone micronized, the sufficient level of progesterone, they provide protection again in the endometrium. There are two major points here, efficacy and safety data. But we can confirm too that clinically speaking, we improve the clinical global impression, we improve all of the menopause-specific questionnaire of life, the MENQUAL, and finally, the most sleep analysis that this is so important, so specific in this study. We can say that the low levels of bleeding and spotting with high rates of amenorrhea is very nice. We can say that this is typical of the hormone treatment therapy, but here with very nice result. And of course, the tolerability was fantastic. Side effects were typical side effects of women that they are taking hormone treatment therapy, and no severe side effects. And finally, no clinical change after 1 year of lipids, glucose, coagulation parameters, liver function, and systolic and diastolic blood pressure and weight. Well, we can say that we are so happy with this new combination that we were waiting several years. Thank you very much.
Thank you, Professor Palacios, for this very informative talk on a new product combining natural estradiol and natural progesterone. Now we are ready for the question time, and I have prepared some questions for my colleagues here. My first one is, what kind of postmenopausal woman could benefit from Bijuva? In other words, can you describe the patient profile that you have in mind? Please, Tim, go ahead.
Thank you. Well, Bijuva is 1 milligram of estradiol with continuous micronized progesterone. So I think it's a very suitable product for most postmenopausal women. It's got lots of advantages, particularly with the micronized progesterone over some of the other progesterones, as I discussed earlier on. So I think most clearly postmenopausal women, that is over 54, or those younger than that who've clearly postmenopausal, would benefit from this, provided they have not got lots of additional risk factors and comorbidities for thrombosis, such as being overweight or having a past thrombotic history. But for the vast majority of postmenopausal women, this would be a very good option to start with.
Thank you for your answer. Now I have another question for you. How important is sleep disturbance for postmenopausal women? Do you think Bijuva may bring advantage? Please, Santiago, go ahead.
Well, thank you, Rosella. As you know very well, as the majority of the sport, we consider that one of the most important symptoms during menopause are the sleeping disorders. In fact, in my opinion, when you sleep bad, they produce, the day after you are very tired and you have some irritability. This is the domino effect. If you don't sleep well, after this, you have a very bad quality of life. Con Bijuva, you know, with Bijuva, we have beautiful results in all of the MUSE sleep questionnaires. In fact, I think that it was the first product with beautiful analysis before we launch. Know that we improve all of the sleeping disorders. For this, I consider that this is fantastic. But let me to say, it's not a strain. because you know the effect of the progestin that they increase the stimulation of the GABAergic system in the brain. It does mean that no doubt that this is a beautiful product in terms of decrease the sleeping disorders.
Thank you for the answer. Now another little question for you. What patients benefit from oral therapy versus transdermal? Please, Petra, give me your opinion, please.
First of all, there are quite a lot of women that actually prefer the oral application mode because they are just used to it from, for example, oral contraceptives. Apart from that, oral estrogens also have a beneficial impact on hair loss, for example, or if hair is growing in the face. So all women that are suffering from those androgenetic side effects of menopause may benefit from the oral application compared to women using transdermal estrogens. And also oral estrogens decrease cholesterol levels, for example. That would also be a benefit.
Thank you for the answer. And now my last question. Do you think that Bijuva could be a treatment option for postmenopausal women who have bleeding concerns? I'd like to listen to the opinion of Santiago.
Well, this question is important too. I can say that first, all of the hormone replacement therapy combination, they have the same problem. They appear in the beginning more bleeding or spotting problems in this way, but disappear over months. I put here the slide clearly that after 1 year, the percentage of women in amenorrhea is exactly 97, 98%, exactly the same as in placebo group. This is true that perhaps we need to say in the beginning when you prescribe in this kind of women, you can say, well, maybe you can have some spotting or bleeding in the beginning, but don't worry, all of these problems are going to disappear over the months, and that means that this is not problematic. Probably it's a question to explain. But on the other hand, the most important one is to confirm that 100 milligrams of micronized progesterone is enough to protect the endometrium. But this is the point. We can confirm the protection, but we can say that probably in the beginning, some women, around 20% of women, they are going to have some bleeding or spotting problems versus placebo, that this is not so much. But if you explain, sure that the women, they are going to understand and you can prescribe.
Thank you for the answer. And now I believe we have come to the end. I thank very, very much all the speakers for answering to my question. I thank the audience for listening. I thank Theramex and EMAS for hosting our symposium. And I'm looking forward to see you all sooner or later. I believe the symposium was very informative. We learn on a new product. We will have a new option to treat postmenopausal women when we go back to our office. Bye-bye.